After the short happiness session, let us start our plenary sessions now. To chair this plenary session, we have with us Dr. R.M. Chabra, Dr. Atul Bhashan, Dr. Ram Babu, and Dr. Neeraj Nishchal. The first session would be an approach to hypercalcemia. Over to the chairs for the conduction of the sessions. Thank you so much.
Thank you. First of all, I would like to, on the behalf of the co-chair, we would like to thank you, the organizing committee, for the SPEEDCON 2022. After the tea break, everybody is alert. So we are going to start the session. Hypercalcemia is a very big problem. Can you have the speaker introduction? Speaker introduction. How to approach a case of the hyperglycemia? We have Dr. Thomas V. Paul.
कहाँ दिखेगा इतना
Slide is not clear. So, I call Dr. Thomas V. Paul.
Yeah, Christian Medical College है ना?
Yes. Dr. Thomas, Department of Endocrinology, he is a senior consultant endocrinologist at the Christian Medical College, Vellore. Sir, please, it is yours now.
Thank you so much, sir. Thank you, chairpersons, and thank you, organizers, for this invitation and hospitality. I am just standing here. The legends are sitting on the front desk. I'm humbled. So next 20 to 25 minutes, I will like to do something on approach to hypercalcemia and little bit of case vignettes also. So one, it start with, like, somebody was talking about vitamin D deficiency, and thing is sleep and vitamin D deficiency was also been described. So when I do, sometimes I have to do the mock exercise. I do it with my wife. So after third slide, she sleeps off. So I wanted to give a trial of giving vitamin D and see whether she retains at least for 10 slides. So my objective is to keep you awake during this plenary. Now, this is my outline of the talk, and when we talk about calcium homeostasis, we talk about three things. One is bone, next is kidney, third is gut, intestine. So this is a 10th standard CBSE portion. Like, the calcium revolves around this, and all these organs control. When we talk about the hormone or vitamin, this is sunlight and PTH. Sunlight, vitamin, that is vitamin D in the form of active, as well as the PTH, which plays an important role. Now, when we talk about calcium, of course, there is a difference in the various labs, but 8.3 to 10.4. And when we measure calcium, we have to always ask for albumin. It should be albumin-corrected calcium. For approximately, for example, 9 milligram of calcium and 4 gram of albumin, it is 9 milligram calcium. If 9 milligram of calcium you are getting, the albumin is 2, then you add 2, that is 11 milligram. It is the hypercalcemia. So when we are looking at calcium, it should be always albumin corrected calcium. And hypercalcemia, classically described many years back, 2 standard deviation, we take a cutoff of 10.3 or 10.4, above which we say. Severity, yes, somebody has got a calcium more than 14, we say severe hypercalcemia, many of them will be symptomatic. Now, this is the first clinical year teaching, that is the PTH The first test, once we document hypercalcemia, is whether the patient's PTH is high or non-suppressed, then or whether it is a PTH independent, as in cases of granulomatous disorders and vitamin D intoxication or malignancy. PTH dependent pathway goes in the line of primary hyperparathyroidism. So if you look at the battery, endocrine disorders like primary hyperparathyroidism, hyperthyroidism, pheochromocytoma, Addison's disease, then genetic causes are there. Drugs like lithium, thiazide, granulomatous like TB, sarcoid, and malignancy, solid as well as hematological malignancy like myeloma. So when we talk about PTH dependent, that is PHPT, then there are so many causes are there, and sometimes primary PTH dependent hypercalcemia can be associated with multiple endocrine neoplasia, genetic syndromes. Now, this is the, once again for the medical students, first clinical year we give this mnemonic. Of course, this is expanding. Vitamin strap, this is how we try to remember most causes of hypercalcemia, whether it is PTH dependent or PTH independent. Now, when we look at the symptoms, the common one can be gastrointestinal, they can have constipation, anorexia, renal, they can go to urologist or nephrologist with renal stone and renal dysfunction. Sometimes they can be depressed, neuromuscular, and profound weakness can be there. Sometimes they can have a cardiac events and bones. Still we see lots of osteoporosis and fractures with hypercalcemia. So this is done by my student Anis. Still we see this kind of significant bone involvement, significant renal involvement, GIT, pancreatitis, all these are still seen in many settings in India. So this is a study from Dr. Mittal, asymptomatic presentation in his clinical setting up to more than 1/3. But institutes like us, we see still majority are symptomatic in our setting because we don't do regular screening in the community. So that is our study. We found that about 90% had a significant bone disease also. Now, when we talk about the investigation menu, fasting calcium and phosphorus associated with albumin, and we always look for the creatinine for the renal dysfunction. And PTH, when the calcium is high, first test is PTH, it has to be collected. It's a very unstable hormone. It has to be collected in cold environment. It has to be transported in the cold environment. It has to be processed almost immediately. Otherwise, we are going to get a wrong result. So that is very important. Rest of the tests are as per the clinical evaluation. So once we know it is primary hyperparathyroidism, we look for the organ damage and localization, which parathyroid gland, by simple ultrasound, isotope scan, 4D CT. Sometime when we come across in clinical practice as a physician, PTH independent, PTH is suppressed, then we look for granulomatous disorders, chest X-ray, skeletal survey, myeloma workup, PET scan to see solid organ malignancy. Now, this is the simple algorithm. Albumin corrected hypercalcemia is there. Measure PTH. Once you know it is PHPT, look for other organ damage and other associated syndromes of PHPT. Then, whereas if it is suppressed, we look for granulomatous disorders, malignancy. Nowadays, post-COVID, covidophobic and vitamin D philic, we see vitamin D intoxication and malignancies and others. Now, the management is 6. One is hydration in volume overload state, hydration and diuresis. Number 2, we give bone calcitonin, we'll give as an injection. Third is a bone anti-resorptive, and sometimes we use calcium mimetic like cinacalcet, and granulomatous disorders and malignancy we use glucocorticoid also. Now, the hydration is little technically difficult sometime in elderly people when they have a cardiac compromise. You have to be very careful. In that case, we assess every hour after giving the fluid challenge. Sometimes we use furosemide, 1 to 2 milligram IV every hour as an infusion for a calciuresis. So, usually 1 to 2 milligram comes down from the calcium level with hydration alone. The next is injection calcitonin, 200 units or 300 units 2 to 3 times. It also brings down calcium, but the effect is very short-lived, 48 to 72 hours. Now, this is a cornerstone. In addition to hydration and calcitonin, we give anti-resorptive to block osteoclastic activity so that you are getting away from reducing the calcium. Zoldronic acid, in many settings we use, the frequency can be, sometimes we use every 15 days also, every monthly also. But somebody has got a renal involvement, we use more and more denosumab, which is a RANKL inhibitor, and used mostly in the severe hypercalcemia as well as malignancy-induced hypercalcemia. So denosumab we are using in PHPT in many of our settings where there is a kidney problem and calcium is more than 14. And denosumab is also been described in many cases of hypercalcemia of malignancy. So the dialysis, yes, hypercalcemic encephalopathy, we may need to do dialysis in addition to the previous measures. Calcimimetic borderline hypercalcemia, and your patient is not fit for surgery, we give Cinacalcet. It decreases PTH secretion from the parathyroid gland. So 30 milligram in many Indian setting, 30 to 60 milligram we give. The reason one is we are using Cinacalcet in PTH independent hypercalcemia. Some of the cancers like CA breast respond with Cinacalcet because they have PTH receptors in the tumors. Now, coming to the hypercalcemia with granulomatous disorders, we use steroids. Even in hematological malignancy, we use glucocorticoids. Now, many of these things, the immediate effect will be seen. Except for this calcitonin, the effect is very short-lived, 48 hours. And whereas if you look at bisphosphonate denosumab, the effects will last longer. Now, this is the summary of management of hypercalcemia, severe hypercalcemia or moderate, acute moderate hypercalcemia. You have to give hydration and calcitonin, then bisphosphonate, sometimes denosumab and Cinacalcet once the calcium is coming down. Then in refractory cases, we use dialysis. Now, I just go to few cases. This is a young lady. During pregnancy, she fractured the femur. And after delivery, she came to us. You can see very clearly, she had high calcium and high PTH. It was a PTH-dependent hypercalcemia, primary hyperparathyroidism. Now, look at the bone density. It is very, very significantly negative, very low bone mass and very significant bone disease in this patient. Look at the, we did a chest x-ray, whether because a young patient, whether any multiple endocrine neoplasia is there. You can see something mediastinal widening. We thought, is it a thymus or something sitting there? But it was not. It was a sternum, became thin, it was bulging out. So, and she had a right inferior parathyroid adenoma in the isotope scan. She underwent successful surgery. You can see the brown tumor sitting there. Then you can see the parathyroidectomy was done. You can see when she came to us, there was the rod has come out, almost come up, and you can see the callus formation after the successful surgery after 3 to 4 months. This is a young, once again, young lady, renal calculi, sustained humerus fracture, getting referred to us. She has got fatigability, and she is quite emaciated. You can see for yourself how the humerus is looking. It is almost disappeared. And she had PTH-dependent hypercalcemia, primary hyperparathyroidism. And ultrasound neck, when we looked at, there was no localization. There was nothing there in the parathyroid. So, whereas when we did a isotope scan, it was sitting inside the chest. It was an ectopic parathyroid adenoma, underwent surgery, and she was okay. Now, this is a case, came in 2020, came to hematology department because of anemia. And she also had some backache and fatigability, and she had a blood transfusion. She had a significant proximal myopathy. If you look at, the hematologist looked at the blood and pancytopenia, bone marrow aspiration was done. Bone marrow biopsy showed osteoclastic infiltration. It was a little like a high turnover. So they wanted to know, the pathologists wanted to know, bone pathologist, is anything related to bone. So the patient was referred from hematology to endocrinology. Look at the calcium. Severe hypercalcemia, PTH dependent hypercalcemia, osteoporosis was there, and lesion was localized. And this patient, after undergoing successful surgery, all the hematological parameters normalized after 6 months. So this is a case, patient presenting with hypercalcemia to the hematology getting referred. This is a young man referred by psychiatry department because he was given lots of antidepressive medication. They evaluated, they found 2 abnormalities, hypercalcemia and low glucose. That's the reason patient was referred from psychiatry. So when a young person comes with hypercalcemia, we have to look for syndromic causes like multiple endocrine neoplasia. So you can see here, PTH dependent hypercalcemia was there. In addition, you can see the glucose was low, hypoglycemia, insulin was non-suppressed. So this patient had 2 things. One is primary hyperparathyroidism and insulinoma. So this was a case of multiple endocrine neoplasia 1. This is this we see gastroenterologists previously 20 years back, they don't do calcium as a routine. Now they do, all centers they do calcium profile when they present with pancreatitis. This was a presentation, index presentation to gastroenterology department with acute pancreatitis, PTH dependent hypercalcemia. So there is definitely in many centers including PGI, Chandigarh, AIIMS, Delhi, we find that hyperparathyroidism can be the index presentation of the pancreatitis is the index presentation of the primary hyperparathyroidism. Now, this is a lady, breast malignancy on treatment, presenting with hypercalcemia. For hypercalcemia, patient was referred, probably metastasis. But when we looked at PTH, it was non-suppressed. So, and also you can look at the renal parameter, vitamin D were normal. So, this patient had a primary hyperparathyroidism as a cause for hypercalcemia. So, it's a dual cause. So, we always look for a treatable cause. We should do PTH. This was a case of hyperparathyroidism on the background of metastatic breast carcinoma. Now, this is a 63-year-old man came to us with hip pain. Orthopedics department is referring to us. X-ray pelvis showing mixed sclerotic and lytic lesion, elevated alkaline phosphatase with the PTH is also high. So it is not prostate, it is PTH dependent hypercalcemia with hip pain. When you look at this X-ray, you can see typical Page's disease is sitting there and primary hyperparathyroidism, 2 bone disease in 1 patient. So mostly they are all easily treatable hypercalcemia in our clinical practice. This is a 47-year-old lady, bone pain and weight loss, and there was a hard mass palpable. And patient had a severe hypercalcemia and PTH was elevated. It was a case of PTH carcinoma, and PTH carcinoma may present with a hard mass. We shouldn't mistake it for thyroid, and we should always do a calcium profile, and you should see it is high index because the management is going to be little more aggressive than simple primary hyperparathyroidism. This is a lady went to ENT department and dental department and referred to us. You can see tumor sitting there, brown tumor sitting there, and it was a case of the brown tumor in the jaw, manifestation of the primary hyperparathyroidism. So the various, they all go to different departments because of the presentation of the hypercalcemia is different. This is a simple case, an elderly person like in a simple Graves' disease coming with hypercalcemia. So you should be aware of that thyrotoxic can cause. This is the patient garden variety in clinical practice, internal medicine, hypercalcemia, PTH independent, sarcoidosis presenting with hypercalcemia. This is a case I was telling with this patient we had in last January. This patient during this last wave, the physician was giving tons of Architol and tons of vitamin D. Patient came with PTH independent hypercalcemia, and at the end of all this, patient got COVID also. So we have to be aware of that. This is also becoming more nuisance. We shouldn't intoxicate patient with vitamin D. Now, this is a case of a renal carcinoma presenting with PTH independent hypercalcemia. On treatment, you can see upward arrow. After resection of the tumor, calcium is normalizing. So it's a case of PTH independent hypercalcemia due to solid organ malignancy. So I like to summarize. They are the primary hyperparathyroidism and malignancy are common cause. Asymptomatic, yes. And identifying the cause and treatment mainstay, hypercalcemia multimodal therapy. Thank you so much.
Thank you, Dr. Pal, for excellent presentation. Even your introduction slide was not clear, but everything was clear except the introduction slide. So you explained each and everything crystal clearly, from the approach of the how to diagnose, how to manage, and you have shown so many cases with the management very clearly. So now, सर अपना इंट्रोडक्शन दीजिए पहले अपना अपना नाम बताइए सर.
Yes, sir.
Yes, no question.
Sir, I have not come across CLD, advanced CLD causing unless there are associated malignancy. I don't have experience in that, sir. Sorry. I don't know the answer. Advanced CLD with, sir.
I have a question.
Yes, sir.
सर इंट्रोडक्शन दीजिए अपना पहले.
Yeah, General Marwa, I'm an endocrinologist. You showed one of the slides where the rod had come out
Yes,
because
sir.
of this. And then you show us another slide with the bone density increasing, but the rod is still there. I was wondering, after how long did you refer these cases to the orthopedic to remove after you've treated the primary hyper?
Yes,
because
yes. Rod,
it is
yeah.
already bone density is increased with the rod inside.
Yeah.
So what is your
Sir,
approach
yeah,
in such
yes.
case?
After the long bone fracture, after successfully treating, our for the any implant removal is we give 3 to 6 months for the because we have found the BMD improvement in 3 months, and it's about 12 to 24 weeks. We give the orthopedics. Many cases they have removed only after 6 months.
Dr.
After-
Wangnu, please.
Yeah,
Yes, sir.
thanks for a nice
Yes, sir.
presentation. My question is basically how you're going to treat a lady with PHPT with non-localization of parathyroid gland
How long?
during the first trimester of pregnancy.
So your question, sir, is how long you are to go into?
No, how you are going to treat
Ah,
first
Non-local.
trimester pregnancy with PHPT, but we are not able to localize the parathyroid gland with hypercalcemia severe.
yeah. It's a little difficult because the problem is also imaging. Only thing is we can do it only ultrasound. The other things are
Treatment,
there.
what treatment you are going to just?
Cinacalcet, we have used it in 1 or 2 patients. We have only 5 patients on pregnancy. 3 are managed surgically, and 2 Cinacalcet in second trimester we are used. We are not used in the first trimester.
Thank you, Dr. Paul.